sorry. That's okay. We're recording. That's fabulous. I am passionate about helping families receive gain access to receive the care that they need. And that is really, that's how I became involved with this work. And so when I am not helping families and working with ASU at fourth trimester, you can find me watching RuPaul's Drag Race, one of my favorite shows. Yes, reading some Brene Brown books, listening to her podcast, and as mentioned, baking. So moreover, to the session today, it is about the science, data, and networks and how they come together to create solutions. And we have a fantastic lineup of speakers that I will introduce in just a short moment. And we are going to look at how collaboration and systems level thinking can lead to healthier, happier outcomes for families and babies. And back to baking, it's like mixing the perfect ingredients to bake up some incredible progress. So please take a look at our disclaimer up here. I'll give you a few moments to read. Now to introduce our speakers, first we have Kate Dobler, which I just learned, the illustrious Kate Dobler. She's this Arizona State Opioid Treatment Authority and the Women's Services Coordinator. She's passionate about improving the lives of mothers, babies, and families in Arizona. She's a change agent who believes in building systems that meet families exactly where they are and offering the support they need at the right time. Kate is all about creating real, meaningful change because at the end of the day, babies live in families, families live in communities, and it takes all of us to build a world where they can thrive. And so next up, we have Diana. Oh, sorry. I was like, I thought she came back. We have Diana Contreras. She is the senior administrator for the Arizona Birth Defects Monitoring Program at the Arizona Department of Health Services. She oversees the statewide surveillance of birth defects and neonatal abstinence syndrome. Diana works with partners all across the state to ensure that families affected by these conditions get the support they need. And she's a champion for collaboration in public health. Last but not least, we have Matt Martin. Matt is a clinical associate professor of behavioral health and the associate director of the Safety Net Advancement Center, SNAC, at ASU, or Arizona State University. He's an expert in healthcare improvement, substance use prevention, and behavioral health integration, a true game changer when it comes to improving healthcare systems. Improving systems of care, sorry. Now, without further ado, I will hand things over to Kate Dobler to kick us off.
Thank you. It's on. I have a green light. So I've never actually had to use a microphone with a green light. So if I wave around up here, you can't hear me. So call me out. So thanks for attending this session and being part of our mighty crew for this conversation. We'll go to the next slide. Once we figure out how to get to the next slide, it's going to tell you all that I'm the State Opioid Treatment Authority. And that's backwards. And now it's time for a break. So we're going to, one more. So in my role as the State Opioid Treatment Authority, I'm a systems builder. And I am intentionally focused in the space of supporting the infant toddler mental health of babies in our state, and specifically the mother-infant dyad in the setting of substance use disorder. And in the role as Women's Services Network Coordinator, now I'm green again. Working to support system connections for women across the age span who are struggling with substance use disorder. So I have this mix of oversight and technical assistance, stakeholder education, and then connections between partners and people doing work. Now we have a picture of Dr. Martin. Diana. So folks on the, yeah. Forks up, this is fun. Folks who are online, you get the outtakes at the beginning. So I know the slides sort of backwards and forwards because this is this is the 5th time that Diana, Matt, and I have given this presentation, and we've really done this. Look, there I am. Woo! As a all right, as a way. We've done this session as a way to demonstrate what partnership can do and what collaboration can do. So as I said, there I am. So I'm a triumphant graduate all the way across the state, and I'm an infant toddler mental health professional. Next slide. I talked about this already. We'll go to the next slide, and we can go to the next slide. And so when we think about what does educating partners across the state about the work of opioid treatment programs and medications for opioid use disorder, it's really the crux of what I do. So I do coordinating with licensing between Department of Health Services, the Drug Enforcement Agency, SAMHSA, Access, Medicaid, sort of all of those partners are part of the oversight system for opioid treatment programs in the state. And then that's also the framework through which federal guidelines are interpreted at the state level. And then I provide technical assistance for way those actually roll out at the program level. And so we are right now in the midst of implementing final rule updates, which is the first time the 42 CFR Part 8 has been updated in over 20 years. And so it's a significant change in the way opioid use disorder is treated through opioid treatment programs with specific impacts for pregnant and postpartum women. Next slide. If we're lucky, it'll go to the next slide. Okay, good. And a significant focus of the updated final rule and the work that the 3 of us are doing around making sure that partners and communities are aware of resources available to support women or to support people in general, but specifically pregnant and postpartum families, is the integration of harm reduction, both education and materials and supplies, and integrating that conversation into active patient care and active connections to resources, which is really grounded on the thought that we need to keep people alive. We need people to be healthy and safe as they navigate their way toward readiness for recovery, treatment and recovery. So engaging in naloxone distribution across the state and then leveraging the fund sources available to do that is a significant part of the work that I do. In this space, if you were not in the ASU conversation across the hallway, there are a couple of kits or cases of naloxone available. You're welcome to take a kit of naloxone for yourself. And then somewhere there's a sign up sheet that if you have a program where you work with populations that would benefit from having naloxone available, please populate that. And then I will be in touch. We'll facilitate delivery of naloxone to you. Next slide. Okay, good. On the Access public facing website, one of the resources that we've built out is a locator service to locate opioid treatment services across the state. This is what the page looks like. There's the address at the top, but you can identify this from the public facing azaccess.gov website. It's a searchable tool, so you can put in the the number of miles from a specific zip code, and then it will tell you all of the resources available in that space. We'll get to that in the next couple of slides. So we'll pull up a PIN dot map, and then the list of the program names and information about those programs. So next slide. For this particular presentation, I pulled a map for a 50-mile radius from zip code 85034, which is in downtown Phoenix. So this is a blow up of the map, shows you much of Maricopa County and down into Pinal and Pima and up into Gila. And if we go to the next slide, I've zoomed in to locations in Tempe, Mesa, and Gilbert. These are, each of these pin dots represents the location of a program that has created a provider profile within that opioid treatment services locator and has said, here's our address, here's the health plans we contract with, here's the services we provide. Either they are an opioid treatment program, a residential substance use disorder treatment program, an office-based opioid treatment program, or naloxone distributor. You can filter for all of those categories of service, that front page, but the point of this slide, a couple points. One, you can get to this level of detail and you can zoom all the way in because it's on a GIS map. These are all, at the second point, these are all of the programs that have created profiles in the locator. Third point, I know there are more programs than this in these zip codes in Phoenix. So when this is a free locator to use, does not require that anyone be contracted with access. It's intended to be an opportunity to identify service providers in the region or in the state, and anyone can list their appropriately licensed and credentialed program on the locator. So if you know, Vicki and Megan, you know treatment providers, hospitals, substance use disorder treatment facilities that fit those categories, we would love to have them in the locator so that we can identify where the resources for our patients. So next slide. This might be all of mine. Well, here's the provider. So this is the front part of the public facing provider card. So you can see the hours the county served, the health plans they contract with, website, phone number, address, and then I didn't get a copy of it, but on the further down, you can see the specific populations they serve, medications they utilize, etc. Next slide. Oh, look, I'm done. So Diana's next.
So first of all, their intro was way better than what I submitted, so I want your copy. I'm telling you, I want the copy. Also, I like this. So while she's pulling it up, during the summer and since April, we did all of these sessions that Kate talked about. We went around the state and did what we called a roadshow to take information out to the communities. And we constantly talk about meeting people where they are, but we actually met the providers where they are. And that was amazing. And I'm going to talk a little bit about data and how I'm not a data person, but I'm such a data person. And that's part of why we have this topic, right? Like data and networks and all of these things, it's a combination that works magic. It's not just, oh, here's my data and this is what I do. I work for the state. I oversee birth defects and neonatal absence syndrome. I'm all about data and surveillance. I'm all about the value of that. But then it's bigger. What do we do with it? What can we do with it? And how do we share it with our partners? And not necessarily the partners that we think about, right? We just had this amazing conversation about we have to think outside the box. So the first couple of slides go through the fact that NAS is reportable to DHS, not just to DCS. We're not talking about child safety. We're talking about understanding the issue. And that was why I got involved with Kate. That's why we've gone through the communities talking about we don't have good data. We don't know what's going on with NAS because we don't have facilities accurately reporting. And we were trying to improve that system. So for anybody that needs to know that, NAS is reportable by facilities, by providers, by anybody who comes across. It doesn't have to be a hospital. It doesn't have to be, that level. We want to know what's going on with these kiddos in the state. It should have just been on the end of her presentation. She merged them. Was it not? It wasn't a separate presentation. It was just merged. Okay, so the tool that we developed through the day that we were receiving, I can do most of it without the presentation, it's fine. But we're creating a dashboard so that a public facing dashboard, so anybody can go and look and see what's going on in the state with NAS, what the populations are. We can drill it down by county. We can drill it down by demographics. We can look at, was mom college educated, married, not married, where she was, where did she deliver? Was it a home birth? Was it an intended home birth? We have so many select categories to really try to understand our community. So Gila County can look at Gila County and say, what's the education level of the moms that are delivering family, babies that have NAS? Jump ahead. So okay. So again, just a lot of different options. I want to save time for Matt. I'm usually the sandwich of this presentation and I try to, or the middle of the sandwich. So I try to make sure we have plenty of time for Dr. Martin. But the tools are only as good as the data we have, right? The data is only as good as who reports. And so go ahead to the next slide. Go ahead. Okay, so this is where the relationship and the partners come together. That this is the gist for this summit, talking about workforce, talking about serving this community and how we do this whole as a fourth trimester community. It's about that relationship. It's about that partnership. I don't know how many times I've been in a meeting where you connect and you're like, oh my gosh, we should exchange information and talk. And then you never do, right? So Kate and I had that happen. And we actually followed up and we started meeting every other week just to meet, just to talk. And at first it was very formal and very like, oh, this is what I do. And this is what I do. And what can you do? And then we developed this relationship. So in my work, so I oversee birth defects and neonatal abstinence syndrome, like I said. They're very similar in the processes and they're very, very different in the processes. It's very specialized work. Nobody else does what I do in the state. We have a lot of shared interests. We have a lot of, women and children's interests. We have a lot of outside interests, especially with NAS and what's going on, what do we do? But I'm not the person that does all of that. I'm not under the same bureau of the people that do that. So I'm not always invited to the table when maybe I should be. So that's why I say kind of the competing processes, the competing rules. Everybody has different guidance, right? I'm forced to think outside the box because I'm not always at that table. And because I do have different requirements or different responsibilities. You can go to the next slide. So in doing that, it forces these conversations because if somebody else has money that's guided by a certain thing and I'm like, hey, we should do this, maybe they can't do that, but I really want to do it because it's required under my grant, but it requires somebody else to do it. So that's where these conversations came into be, right? So through the conversation, Kate said, hey, I just got awarded this money and I want to I have this idea to take this information out, but I don't know what else to do. And it was, technical assistance is kind of the guidance related to substance abuse. I'm like, well, hey, maybe we could assist facilities in reporting. And what would that look like? And through our, conversation, like I said, it turned into not just a partnership, but a relationship where it was safe for me to say, hey, what if we did this? And she said, well, hey, I don't know. And it turned into this thing where we got to go travel and talk to communities and meet people we never would have talked to. You go to the meetings and you see the same faces at the same meetings and they're amazing. They're wonderful. Happy to see you. But it was amazing to go to Lake Havasu and talk to people that live in Lake Havasu. It was incredible to go to Yuma and talk to people that don't ever leave Yuma because they can't. I mean, funding is different, you know what I mean? They have different priorities. They don't have the same resources. So look out in a room and see people that you've never talked to before. That was amazing. And then to be able to share the work that we're doing to improve reporting, but also to help them think that the people that you normally think about might not be the people that need to be at your table. Go ahead. So because of the group we're talking to, I don't want to talk so much about the dashboards and the data. I want to talk about the relationship part, and I promise I'm almost done because you need more time. Go. But it's just that bigger thinking. And I know you guys know, but I feel like it doesn't hurt to hear it. Relationships are bigger than partnerships, right? Collaboration requires relationship, not partnership. When you create the listening space, you create the learning space, and that's where you grow, and that's where you can work together. We felt safe talking to each other. We felt comfortable bringing up random ideas that didn't make sense, and all of a sudden it made sense, and it turned into this amazing thing. And we want to translate that into what we're doing with moms and babies and families. We want to build relationships with moms and babies and families, not just with our office mate, right? The success in this world is going to be, especially in this environment, is going to be based on that relationship. Go. Sorry. This is really obvious, but I thought this was just kind of bullet points of all of the things that we need to create in all of these environments. And I think we talk about it in some arenas in the community. Like, we know we have to create all of this in community, but we also have to create this professionally. How many times do you go to a meeting saying, okay, we need to be caring, we need to be kind? Like, all of the attributes that work in one work in the other, and they're critical. And so thinking outside of the box, like I said, in my own agency, I can't get certain things done because we're all guided by the same rules and the same limitations. And sometimes I'm not at that table, to be very honest. Nobody from there is in this room, so that's better. But I'm not. And some things are challenged because they already have their plan and they have their 5-year strategy. And this idea didn't come into that, right? Or there's no line. I've literally been told, oh, I don't have a budget line item for that. Okay. But going outside of my sandbox to the other sandbox has been incredible. It's changed our systems. It's changed, I'm gonna go ahead and be bold and say it's changed other people's systems because what we got to take out into the state. And it's all because we did this. It's all because we sat down with each other. We followed up with that, like, oh, hey, we should talk sometime, which I'm guilty, I never do. But I'm trying now because it's been such an amazing collaboration. And also an example of, holy moly, 2 random state departments are actually working together. Like, this incredible partnership that, for me, there's metrics that go up to the governor's office based on this work. So it's not just us, it's outside of our work. I think that's it, but just double check. Yeah, okay. So I'm just gonna say, continue to hear each other and think outside of your box. And that's what we're all doing here, but do that for your community and also professionally, because there's so much more that we can do if we have that relationship instead of just the partnership. And Dr. Martin.
Really good. Good afternoon. Diana, that was fantastic. Wow. Boy. I'll do my best. Hi, everyone. I'm Matt Martin, and this is the 5th time I think we've, like you mentioned, 5th time we've presented together. I know it reminded me of a story about Albert Einstein. Okay, just stay with me. Stay with me. So toward the end of his career, he was giving lectures, and one day it was like the 20th lecture, and he turned to his driver and he said, I'm so tired of giving this same lecture over and over again. And the driver said, I'm tired of hearing the same lecture over and over again. I've heard it so many times, I could probably give it. And Einstein said, well, you know what? You and I actually look a lot alike. Why don't we change outfits and you give the next lecture? And that's what they did. So they go to the next city. The driver gets up there and he gives a fantastic lecture. And toward the end of the lecture, a man stands up, and it's actually the arch rival of Einstein, another scientist. And he said, I have a question, Mr. Einstein. And he gives this incredibly difficult, complex question. And the driver said, you know where this is going. And the driver said, that's such an easy question. I'm going to have my driver answer that question for you. Okay, now for something completely different. Let me ask, anyone here working in workforce development? Any trainers, educators, supervisors? A little bit? You have a program? That counts. Okay, anyone working in behavioral health care? Mental health? Yes, okay. Yes? All right. Anyone working with populations that maybe have mental health needs? Okay, yeah, several more hands go up. Certainly, there is a consistent need. Okay, thank you. So here in Arizona, Arizona ranks toward the bottom in access to behavioral health services. And we also rank pretty low when it comes to maternal health outcomes as well. So part of the project that I'm going to share with you was our effort at try to identify individuals, clinicians, who not only can help to treat opioid use disorder, but also have specialized training or have expertise and treat or provide women's health care. So this is a challenge. So right now, the gold standard for understanding workforce needs is from the federal government. They have something called health professional shortage areas. And so they use several data sets, and you can look up your county and your area to see if it's a shortage area. They have it for primary care providers, for mental health providers, and then for dentists. And so three pretty broad categories. And so if you go in there, you can see what counts as a shortage area. And this has been very helpful for deciding where to put money. You know, we have limited resources. There's actually, we have a huge need for more primary care providers and more behavioral health providers. And so this is a great way to identify where are those areas that we can put these limited resources, like funding and whatnot. Yes, please, you can fly through this. Here's my team. There was the funding, bless them. Thank you for the funding. Yeah. Okay, so let's just talk a little bit about opioid misuse. So it's still an ongoing problem. There is some evidence that it started to flatten a little bit, the number of overdoses, and maybe even gone down a little bit as well since the pandemic. It's particularly a high risk for young adults. They're misusing a lot of opioids. Next slide, please. We know a lot about protective factors and risk factors, and this is important. You can go, I think there's like maybe 10 here. Thank you, yeah. We know a lot about these factors, and this is important for the maps that we created. So we know that these are individuals who are not using for the first time or who are successful in recovering usually have these kinds of factors. And you know, when you read this, it makes a lot of sense. These are important resources. Next slide. Same thing, yes. So we also know a lot about risk factors. What increases the chance of someone misusing for the first time, or maybe even overdosing or having a hard time with recovery from opioid use disorder? Let me just stop right there. So opioids have been incredibly difficult because of the way that our bodies react to them. There's been some imaging studies where they've done to see what is the impact on brain activity by opioids. And so one of these studies that they did was they had individuals look at pictures of food, and these are individuals who had been fasting. And so there was like brain activity that was maybe the size of like a baseball. And then individuals who had a history of like alcohol use or misuse. And so they showed them pictures of alcohol, and there was significant brain activity, maybe the size of like a basketball. And then for those who had a history of opioid use, they showed them pictures of opioids, and the brain just went wild. There are activity all over the place, relative to the size of a football field. I mean, just incredible responses. And so that's what we're dealing with. We're dealing with something that our bodies just have such strong reactions to. Okay, so this is what we know about those individuals that are at more risk compared to others. Next, please. Okay, we can go through these pretty quickly. These are just specific criteria that clinicians use for identifying a person who has OUD. These are individuals that have constant cravings. They have a compulsion. They continue to use despite the intense consequences that they're going through. They are experiencing incredible lack of control over their use as well. Next slide, please. These are more diagnostic criteria. You can see the cravings they continue to use despite the problems in their life. And they're giving up a lot of things that they previously enjoyed doing to satisfy the opioid use. Okay, next slide, please. All right, and then just a little bit more about tolerance. The tolerance is important because, thank you, because of the timing. It's not only important to provide this treatment, but at the right timing. Individuals that go into incarceration, they experience withdrawal, and so their tolerance goes down. When they leave the jail, their tolerance is so low, but they might continue to use at the same level, and they have a risk of overdosing because of their low tolerance. So the timing is important as well. Next slide. Okay, the gold standard is MOUD. So these are medications, methadone, buprenorphine, you may have heard of them. Some individuals just need the medication and that's enough. These medications have been around for a long time, but it's really difficult to get clinicians to begin prescribing them. And I'm talking about primary care providers, individuals that normally don't work in addiction medicine. The federal government has been very good at getting a lot of people to do the training for how to prescribe them. These are not too complex to prescribe, but it's been very difficult to have clinicians open their doors and have these kinds of patients come in. Next slide, please. So the goal is right there to reduce symptoms, cravings, risk of relapse. And then naloxone was talked about already. I was so happy to see the table out there with that supply of naloxone. Okay, like I mentioned, access is a big issue. You can go to the next slide, please. And there's been an incredible change within the last couple of years. Clinicians no longer need a special waiver to prescribe buprenorphine, which is wonderful. Next slide. Okay, so our project, actually, will you go a little bit farther until we get to the maps, and then I can just give a background. Thank you so much. Okay, buckle up, hold on. Here we go. I hope nobody gets nauseous. Yeah.
Oh, yeah, so those are the links, they're live.
Yeah, you can go to the next slide. It should show one of the maps. Okay, thank you. Okay, so this goal, we were trying to identify individuals that are not only prescribing these medications that we know work, but also have that expertise in women's healthcare. And so at first, what we did is we just started calling up clinics. And, you know, I'm a clinician. I thought, these are my brothers and sisters. They're going to answer the phone, you know, but hardly anyone was answering the phone. As if you're a patient and you try to get a hold of your provider, it can be very difficult. So we put that to the side and we started to use administrative data, claims data, encounter data, which we felt was going to be a little bit more reliable. So after identifying the right data sources, we found these individuals that met the criteria, and then we mapped them. So this shows the locations of individuals that have that MOUD plus PPW, pregnant and parenting women expertise, and their locations. Now, this is not 100% accurate. There are probably some issues with this. We have to do data validation. There are probably some individuals that, you know, they might work at one clinic half the week and then they go to another clinic half the week. So we might be counting them twice. But this gives us some idea of where the density is. And, you know, it makes sense. These are in the urban centers. And it also gives us an idea of where can we put more resources? Where can we encourage more people, more clinicians to get involved in this work? It's been fantastic being part of this series of presentations and going to other parts of the state and better understanding what their needs are. Next slide, please. So if you go to the website, you can actually zoom in to your neighborhood. I may or may not have done that. I was just curious, you know. I was just curious. So this shows the Phoenix metro area, and you can see exactly where these providers are located. Next slide. Okay, another thing that we did is we wanted to put together risk scores. So what we did before is pretty similar to what the federal government has done for a long time, is just identifying where these providers are. What we wanted to do was to better understand risk across the state for future overdoses. And so we used multiple data sets and we created a novel risk score, and then we mapped it across the state. So here you can see 2016 compared to 2020. And before the pandemic, there was actually a trend of improvement for opioid risk. We haven't done it since the pandemic, but I imagine that there was a bounce since then. But yes, right there, left and right, it shows that we were actually headed in the right direction. So blue means that those areas have lower risk. Red, orange means higher risk for future overdoses. Next slide. And then this is just the Phoenix area. So you can see with this kind of geographical data, you can zoom in and see actual like census tract areas, neighborhoods. Next slide. This is 2020, so there's more blue. It was trending in the right direction. Next slide. Here's Tucson. So Tucson, just looking at it visually, it does seem that Tucson does have higher risk compared to Phoenix. Next slide. And then more blue in 2020. So the risk was actually decreasing. Next slide. Okay, so we still have work to do, like the data validation that I mentioned. We're doing some additional analysis. Next slide. This is the additional analysis. We're doing an optimization model that policymakers can use to decide where to put more resources. Next slide. Okay, and then we have a new project that is actually starting pretty soon. This is a project focused on Northern Arizona. This was written by Kate and her team and awarded by SAMHSA. We have 3 years to try to improve the healthcare system in Northern Arizona for PPW who have a substance use disorder. So we're really excited about it because we've got fantastic providers and clinicians in Northern Arizona. What we hope to do is try to connect the systems in stronger ways, try to fill in the gaps between those providers. And I think that is it. Next slide. We're not going to read these. Okay, if I can't remember if are the slide decks available to the audience? Okay, great. You're welcome to contact me if you have any questions. Thank you.
I have a question for you guys. Are all of the providers in the maps and community cares, or have you connected with community cares to make sure they're part of the closed loop referral system that Access funded so that hospitals can close the loop?
Well, thank you so much for asking that question. Thank you.
You're very welcome,
I
Kate.
so much appreciate the segue. No, the answer to that question is no. So I'm going to talk a little bit about your data set. So the data set that informed the heat mapping, right, is paid claims data, as opposed to providers putting themselves in the closed loop referral system or into the opioid treatment locator. So these are paid claims, which means there's some lag time in when the actual services were provided. But so these were providers who actually submitted claims for the treatment of this population to provide buprenorphine in the setting of opioid use disorder specifically, but not from a closed loop referral. That needs much help, right? There's a lot of help that's needed to get past bias and stigma, to get primary care providers who in Arizona, anyone with a nurse practitioner license or higher can prescribe buprenorphine or naltrexone for the treatment of opioid use disorder. Anyone, right? That doesn't happen. So we have a whole lot of providers who have the training, who did the X waiver training from SAMHSA that Matt was talking about, but they're not actually providing the treatment. They're not actually writing the scripts, which is why I wanted to look at, well, where are women actually receiving services? Who's actually doing the work? And then what does that tell us about the landscape of the state. So one of the things that I think is fascinating, looking at the map of, and these are live links, so you can go and play with the filters and all of that, but when you look at the purple icons that was on that map, those are providers who provide both substance use disorder treatment and treat pregnant and postpartum women together, right? Same provider treats this population and does this. And then the zoom into the Phoenix area, compare the locations of all of those with the locations on the same map that I pulled from the opioid treatment locator. And we see probably 4 times more claims paid from different providers for opioid use disorder than we see in the opioid treatment locator. And so that's part of how I wanted to see is like, well, who are we paying? And do we actually have them in a locator so that folks who are doulas or community health workers working with families can go to a public facing space and connect them with someone in their community? And the answer is no, they're not there. So I have leverage with opioid treatment programs because they're a special animal, but office-based opioid treatment, which is, stop now, which is primary care providers, we don't have any, we need help. So Zaha or whoever else can help the system level, that we need that help because we need people to be able to find the treatment.
Can we get a round of applause for these fantastic speakers? Yes. Thank you all so much for attending and for your lovely questions. Fantastic, well timed. I do have some brief announcements. The next session starts in just 5 minutes, so quick to the restroom, do what you need. And then don't forget about the raffles if you have any tickets. And we will see you back at 2:20. Please let us know if you have any questions. Thank you all.